Hi, welcome to Module 1, EKG Foundations. Let's go ahead and get started. So what is an EKG? An electrocardiogram or EKG, ECG, it's a simple, non-invasive test that records the electrical activity in the heart over time. This produces a tracing of wavy lines, and the goal of this course is to really teach you how to read and understand those wavy lines. And these represent the heart's electrical impulses as they travel through the heart muscle, which triggers the heart to contract and pump the blood. Now, this allows clinicians to assess things like heart rate, rhythm, timing, and strength of electrical signals that are passing through the heart at each moment in time. So why would we use something like this? Well, put to very simply, they're the most commonly used laboratory procedure for diagnosing heart disease due to their safety, simplicity, and reproducibility. This is often one of the first tests that are performed when evaluating for symptoms of chest pain, palpitations, or syncope, and it's very essential for the diagnosis and management of acute coronary syndromes and arrhythmias. We see EKGs across the healthcare field, from being used in the emergency department to the cardiologist clinic to cardiac rehab to exercise physiology and so on and so forth. Now, the basics of the EKG waveform that we're going to go over here is that electrical signals are translating into these mechanical contractions. And this is the foundation of everything that we need to talk about here, right? So if we've got the P wave to start us off, right? And the P wave can be denoted by this waveform here on the EKG. Now, the P wave represents atrial depolarization, which translates into atrial contraction. So when we see a P wave, we know that that is representing the contraction of the atria. When we see a QRS complex on the EKG here, we know that that QRS complex represents ventricular depolarization, translating into ventricular contraction. And when we see a T wave on the EKG here, we know that that is ventricular repolarization, which is representing ventricular relaxation. Now, the key here is, a question that I often get asked is, well, okay, we see ventricular has both a depolarization and a repolarization that are denoted on this graph tracing, right? But where does the P wave relax? There's no P wave repolarization. And you're right there, it's not represented on the graph. We often consider that P wave repolarization to be buried within the QRS complex here. So it's not something that we would necessarily see on the graph, but it is something that is still obviously happening in our physiology. And that kind of leads us into our next little topic here. So each cell in the heart is capable of spontaneous depolarization, meaning any cell in the myocardium is capable of starting the depolarization cascade across the heart. This is unique to the heart, and it's one of the most amazing things about it. This depolarization, obviously, as we talked about, triggers that mechanical contraction. Now, the timing, sequence, and morphology of waveforms reflect the integrity and function of the conduction system in myocardial tissues. So that kind of brings us into, let's talk about the cascade through the heart, starting at the SA node, leading all the way into our Purkinje fibers. So we're going to start with the SA node, which is right up here. And that SA node is going to obviously perfuse throughout the atria to spread the signal through the atria. And it's going to coalesce into our AV node. Then we're going to go into our bundle of His, and then split into our right and left bundle branches. And then each bundle branch will split into an anterior and a posterior fascicle, which will lead us into our Purkinje fibers, which actually connect with the myocardial tissue. Now, electrophysiology and waveforms. Let's talk about depolarization and repolarization. At the cellular level, the EKG reflects the summation of action potentials generated by ion fluxes, primarily sodium, potassium, and calcium across cardiac myocyte membranes. Now, abnormalities in these ionic currents manifest as changes in the EKG intervals and waveforms. So we've got this depolarization or sodium influx, which is going to represent our cardiac or our QRS complex here. And then we've got our repolarization or potassium efflux represented here with the T wave. Pacemaker versus conducting versus myocardial cells. That's kind of the next topic. All right, so these are distinct cell types with specialized roles in cardiac physiology. Now, the basic here is that we've got this pacemaker cell here, and we're going to have this electrical signal that starts in the pacemaker cell, and that's going to make its way through the rest of the cells throughout the heart. So pacemaker cells are primarily located in the SA node and the AV node. They possess automaticity, meaning they can spontaneously generate action potentials without external stimulation. These quite literally are going to set the pace of the heart. They have a unique ionic current featuring the slow inward sodium and then the calcium current. So we've got this slow inward influx of sodium here, and then we have our rapid influx of calcium, and then our outflux of potassium signals our repolarization. Now, conducting cells form the specialized conductive system, including our bundle of His, bundle branches, Purkinje fibers. Now, the goal of these are to rapidly transmit electrical impulses from pacemaker regions to the working myocardium. These are characterized by fast conduction velocities due to the large diameter and abundant gap junctions, but they really lack significant contractile function. And then we have our myocardial cells. These are the working myocytes. These are the guys who are doing the heavy lifting in this whole pumping of the heart, right? They make up the bulk of the atrial and ventricular walls, but they're responsible for the contractile force of the heart. Now, these don't possess automaticity under normal circumstances, but they respond to impulses delivered by the conduction system. But if we remember what I had just mentioned a little bit earlier, of course, every cell in the heart is capable of automaticity, but not necessarily under normal circumstances. In a normal functioning heart, we're going to start with the SA node or the AV node and then kind of bring it on through there, right? Now, if the SA node and AV node fail, that is when we might see a myocyte starting the cascade. Or if there's a cell out in the myocyte that is wanting to start the party and it shouldn't be, that's when we can see arrhythmias on an EKG. Now, action potentials for these myocardial cells are longer in duration, and they feature a prominent plateau phase due to the sustained calcium influx. And this is essential for excitation contraction coupling if you think about the work that this muscle tissue is doing to pump the heart. And so if we look at our graph here, we've got our depolarization here. Our plateau is the key of the myocardial cell, and then our repolarization via that potassium efflux. All right, so we talked about our P wave, our QRS complex, and our T wave here, but let's go into a little bit more depth and talk about some of our intervals. We've got our PR interval, which is going to start at the beginning of our P wave and end at the beginning of the QRS complex. We've got the PR segment, which can be just the end of the P wave to the beginning of the QRS. We have our QRS interval, which starts at the start of the QRS and ends at the end of the QRS. There's the R to R interval, which is going to start at the top of the R wave and end at the next. And then we've got this big one over here, the QT interval, which is going to start at the beginning of the Q wave and end at the end of the T wave. Let's talk about amplitude and timing. The whole thing about an EKG is this, more than anything else, is a graph. We've got a y-axis and an x-axis. Now, the x-axis is going to be time, and that's going to be represented in seconds. And then our y-axis we can represent in millivolts, or sometimes it's commonly denoted in millimeters as well. The big key here is that we have to think about, when EKGs first came out, we had this like sheet of paper that was rolling out at a specific speed as these needles were denoting this graph. And so when we talk about the speed of the paper, that's really what we're talking about here, and that's why we can denote it as time. So the paper speed is usually, or traditionally, 25 millimeters per second. And that allows us to say that one of these small boxes here is worth 0.04 seconds or 40 milliseconds. And then if we count out 5 of those small boxes, which kind of equates to our one larger box, that would be 0.20 seconds. Going up in our amplitude is what we do with the y-axis. We can just count the number of small boxes kind of going up and down, or large boxes. So if I wanted to count from the top of this R wave down to our kind of isoelectric line where that PR interval is, we'd have 5 boxes, 10 boxes, 11, 12. So this would be 12 millivolts here for our amplitude. Now you take a stab at this. Go ahead and pause the video, see how you do, and we'll go over the answers on the next slide. Alrighty, so our PR interval. Now, the key with any reading of EKGs is you want to pick out a really good example of a waveform. Theoretically, I mean, there might be some variation from one to one, but if you're looking at a 12-lead EKG, you want to make sure that you're picking a good example of something to look at so you can get an accurate point for data. So in this case, I'm going to pick this P wave right here for our PR interval, right? And so we start, and I like to draw lines on here so I actually can see right where things start and end. So if I count 1, 2, 3, 4 small boxes roughly, that's going to be our PR interval, which is going to give us that 0.16 seconds. And we can repeat this process. You're going to choose a really nice example for a QRS interval. It's about 2 small boxes. You can translate that into 0.08 seconds. QT interval, 0.36. And then we talk amplitude. Again, you can just measure the height of something from baseline, which is always our isoelectric line, going up. All right, electrodes, leads, and EKG deflections. This is, again, foundation to the EKG. We're talking electrodes here, which moves us into a little bit of a different topic, but hopefully we'll break it down to a way that's digestible for you, okay? Movement towards a positive electrode is going to create a positive deflection. Movement away from a positive electrode is going to create a negative deflection. So we have that positive deflection, just means we have this isoelectric line here. Positive, we're going up, right? Movement away from the electrode, we're going down. So if we have our positive electrode and movement up, we're going positive, and then movement away from the positive is a negative deflection. Now, if the movement is perpendicular to a positive electrode, we can either get this isoelectric line here or a biphasic deflection. So we have all these electrodes that we place on the body that allow us to see the heart in 2 different planes. The planes are the limb leads, which create the coronal plane, which is this kind of outer circle here, and then the precordial leads create our transverse plane going around the side. All right, Einthoven's triangle and the limb leads. Einthoven was the man behind the magic, started this whole thing. He stuck his hands and his limbs in some salt solutions back in 1901, and wada bing, wada boom, we got an EKG. So this is colloquially named his triangle. We give him credit for the thing. And this gives us our first 3 leads of the EKG. We've got lead 1, which will go from the right arm here to the left arm. Lead 2, which will go from the right arm to the left leg or foot. And then lead 3 goes from the left arm down to the left leg or foot. Now, a big question here that we often get, why don't we have a right foot or a right leg that's denoted here or represented? And the reason for that is the right leg, even though we put that sticker on, we put an electrode on the right leg, it's our ground. And so it's not going to be represented in any of the positive or negative electrodes, but it's always going to be present on the body. Now, Einthoven's triangle was the beginning, and then through that we were able to create 3 different augmented leads. And so this is lead 1, remember here, right arm to left arm. Lead 2, right arm to left leg. And lead 3, left arm to left leg. Now, for AVF, I want you to think AVF is foot, all right? So if you're thinking ground, our positive electrode is the ground. And then what we did is we kind of created this like hybrid between the 2 up here. So we've got this like hybrid signal going straight down to the left foot. So AVF foot, right? AVL, same sort of thing. We've got the positive over here on the left arm, and then with this kind of hybrid signal on the other side. And then AVR on the right arm, and this sort of hybrid signal on the other side. And so that gives us our 6 limb leads, 1, 2, 3, AVF, AVL, and AVR. And then we have our precordial leads. These are V1 through V6. And these, again, are in the transverse plane of the heart. So instead of kind of looking at a heart as we will often see it in the anatomical positions, we're going to think that we are slicing through the side of it. We're taking a cross section of the heart, and we're looking at it at those different angles. Remember, the orientation and deflections, whether a lead is positive or negative or isoelectric, depends on the direction of the electrical current in relation to the positive electrode. So over here we have our positive electrodes for each leads, and then our negative electrodes is a little less relevant here, but just for your reference. And so whether or not a lead is going to be positive, negative, or isoelectric is going to depend on which of these electrodes is considered positive for that lead. And that can bring us into this next kind of level here, is when we think about what picture or what view of the heart are we getting with each lead. And so we often talk about lead 1 and AVL. These are going to be our lateral sides. And if we look at our kind of graph here and we look at these red sections as well as V5, V6, this is kind of our lateral side of the heart looking over here, right? And then we've got 2, 3, and AVF. This is going to represent our inferior leads, looking at that inferior side. Again, this is because of where the positive electrode is that we're able to see this different view, this different section of the heart. Our anterior leads are V2, V3, V4, kind of represented here. And then AVR and V1 are our right-sided. And then this gray box down here denotes our rhythm strip, and that quite literally means this is the strip that you're going to look at a 12 lead that denotes the rhythm kind of over time. Each of these other little boxes here can give you a picture, a window, but it's not the best to describe rhythm. Sometimes each of these boxes along the side are the same couple seconds, and so you can't really denote rhythm, because in order to see the rhythm, you need to see it over time. And so this bottom strip, the rhythm strip, gives you that. And the last thing I'll kind of follow up here is, the precise anatomical positioning of each electrode according to standardized protocols is absolutely required. If you switch the electrode placement or you connect the wrong wire, this can result in significant EKG changes. It can make things upside down that should be right side up, and that could mimic or obscure pathology, lead to incorrect diagnoses. And there's some references for you, and I'll see you in the next module.